it's a pleasure to be here. I wanted to make one comment, and I think perhaps if you want to take home something from today, one of the most important things is that to remember is that 95% of patients who develop esophageal cancer never knew that they had Barrett's. I'll repeat that. So 95% of patients who develop esophageal cancer never knew they had Barrett's. So that means we're not detecting them, which means that everything that we know about screening is in 5% of the total population that we're detecting with our efforts. So clearly what we're doing isn't working. It's important also to remember that in all stages of esophageal cancer, tumor cells can be found in the lymph nodes, bloodstream, and bone marrow simultaneously. And in parallel, there can be mutation, selection, clonal expansion, and genetic diversification of those tumor cells in the same patient. So what I'm trying to say is that this can lead to an ever-changing group of tumors or tumor cells within a given patient, which explains the reasons for resistance to chemotherapeutic measures. So based on that, it's intuitively appealing that you take patients with GERD symptoms, you screen them for Barrett's. Once you find Barrett's, you survey them and you detect them, and you prevent death. But things aren't always as they seem, and just because that seems like it might work, we know that it doesn't. So screening does not work. It doesn't work because, let's see here, there's few preventable deaths. So we're looking for the needle. So there's 7,000 patients that develop this cancer in the country per year. There's 10 million with GERD symptoms. That's the haystack. 40% of patients who develop cancer have never even had a GERD symptom. So that drops your 7K down to almost below 4,000 that you're looking for. Screening efforts only detect 5%, as I mentioned. And we don't even know the prevalence of the risk factor that we're looking for. So the range has been reported anywhere from 1 to 25%. If the prevalence of Barrett's was 25%, it wouldn't be a very potent risk factor. Endoscopy is expensive and has risks. So is there an easier way to identify Barrett's patients aside from screening the masses of people with heartburn and regurgitation? And in an attempt to address this, we developed the Barrett's Esophagus Risk Consortium. Well, what is it? Well, it's our desire to understand BE risk in its truest form. So if you were to stand in front of the market and scope everyone who came in, what would you find? And we've never really addressed that question. So in this consortium, we realized we needed to scope 10,000 patients. We needed ease of screening, so we had to overcome the difficulties that are current in sedated endoscopy. And we needed resolution, so we had to query risk factors that had biologic plausibility. So the aims of this study were to determine the prevalence of Barrett's within the nation's primary care population as a surrogate for the general population. So we'd hang out in primary care clinics and scope people. And from this, we wanted to develop a probability model that predicted the presence of Barrett's regardless of their GERD symptom status. These are all very important questions because we're trying to get at that 95% of patients that we aren't detecting. And this is a hypothetical model, but the way it would work would be that, let's say that these were the risk factors that fell out. This is a nomogram. With each risk factor based on, primary care physician could hold this in their pocket. And they would give a score for each one of these risk factors, total the score, and that would give you a likelihood of the presence of Barrett's esophagus, which could trigger screening. And this is BERC. I'm happy that John and Jeff Peters are part of this. But it's primarily the leading gastroenterologists in the country, and we've been able to piece this together and have NIH funding to do so. But the thing that makes it all possible are these devices here, which are the transnasal endoscopes. They're anywhere from 3.9 to 4.9 millimeters in diameter, and they go through the nose, and you can do them right in the office, and they're very easy to perform. This is one of our patients. You can see they're sitting in the upright position. They get to watch the procedure. This is a guy, by the way, that just had cough. He never had heartburn. And he has long segment disease and had high-grade dysplasia. This was pre-Barrett, but we ended up resecting him. So we studied this. We said, okay, if we're going to use this transnasal approach, we have to validate it. So we did a randomized study comparing conventional endoscopy to transnasal unsedated endoscopy. And what we found was that there was a complete equivalency. And in fact, the willingness to repeat the procedure, this questionnaire was after they had it, was greater for the unsedated approach. And the reason for that is their spouse didn't have to take the day off work. They didn't have to have an IV. They weren't sedated for the rest of the day. And there was an equivalency in Barrett's diagnosis and dysplasia. So I think that's the most important part of my talk, because all the other cool stuff that we're talking about, ablating these patients, are only the patients that we detect. So I think that's the most important piece. But let's get into some other things that we're working on. So once someone has a diagnosis of BE, how do we best survey them, and how do we predict progression? So we're talking about, the first part was talking about decreasing the size of the haystack. This part is talking about increasing the size of the needle. And how do we do that? Well, we encounter several challenges in surveillance. Cancer and dysplasia are multifocal. Compliance with the Seattle protocol is poor. Surveillance intervals are not evidence-based. Dysplasia diagnosis, as John had mentioned, is observer-dependent. There's a lot of intra- and inter-observer variability. And in this study by Cameron, this is a hypothetical patient with an 8-centimeter segment. If you do Seattle protocol, you're only detecting 2% for that given level. So if this patient had 8-centimeter segment of Barrett's esophagus, you're leaving 84% of that total surface area unexamined. And the reason this is important is that the prevalent cancer rates in patients with high-grade dysplasia has been reported up to 37.4%. So when we stage multifocal high-grade with or without a nodule, we do everything we can. We throw the whole kitchen sink at them with the things that we have in our tool bag. But it doesn't let you sleep well, and it leaves you sleepless in Seattle. And so the goals of a novel imaging method, so what we need to do is really impact sensitivity. So if we had a novel imaging method, we want to detect dysplastic changes at the nuclear level. That is, we're endoscoping somebody and we want to look at the cell itself, the cell ultrastructure. We want to have microscopic resolution. We want to be able to scan the entire esophagus and not miss anything. We want to differentiate dysplasia from inflammation. And we want to have inter-observer agreement, as well as localize, perhaps most importantly, the dysplastic areas for biopsy. That's a pretty tall order. What I'm going to do now is I'm just going to blow through some of the currently available tools that are out there that are up and coming, but none quite fits the bill of those requirements. There's magnification endoscopy, which is coupled with a chromoendoscopy, such as indigo carmine. Patrick Sharma spearheaded this and found a distinct morphology and was able to detect all high-grade patients, however could not differentiate low-grade dysplasia. Perhaps the most useful one is narrowband imaging, which I really use in my practice on a day-to-day basis. It's high-intensity blue light with narrowband filters, and this emphasizes the mucosal details. Here's some pictures of that, again from Pratik Sharma, showing the nomenclature which has been developed out of this. And it is very good when you have irregular or corkscrew patterns to detect high-grade dysplasia. Here's a similar study from Kara et al. Perhaps the most well-noted is the Tandem study with comparing white light endoscopy and narrowband imaging in 65 patients. So what they did is they scoped the patient with white light endoscopy. They left the room. Another endoscopist came in and then did narrowband imaging with guided biopsies. And then they compared what they had seen. And narrowband imaging detected more cases of dysplasia, and they required fewer biopsies to do so. And they also detected higher grades of dysplasia. And this has been really a useful adjunct in my practice to identify things that are abnormal, biopsy them in a targeted fashion, and then go ahead and perform the Seattle protocol. What about OCT? This is processes coherent light, which is backscattered into a processor, and it gives you pictures with microscopic resolution. But you can see they look very similar, don't they? But you have normal squamous epithelium, Barrett's, high-grade dysplasia, and cancer. and they become more ratty as the disease progresses. There's confocal endomicroscopy, which is essentially an in vivo microscope where you can evaluate ultrastructure. There's autofluorescent endoscopy. But there's current limitations. And the limitations for total surveillance, you can't distinguish low-grade dysplasia. Endoscopists would need to become pathologists. You'd have to be, you have to have a lot of time to sit there and go through these patients, and the inflammation can lead to false positives. And there is clearly a paucity of studies and data on these modalities. So one thing I want to draw your attention to here, here's the modalities. Nothing achieves an A in sensitivity, which is perhaps the most important aspect of these devices. What about tissue interstitial fluid for detecting or developing a blood test? And that's something that we've been working on, is that if you were to take fluid adjacent to the tumor, could that be used to direct the way that you identify a blood marker to get the blood test for Barrett's esophagus? And so you could imagine if you took that, a bite of that tumor and then looked in the bloodstream and used proteomics to develop that, you could do so. So let's go to emerging therapies. ESD was already covered. People are now using cell sheets to prevent stricture formation. So this is an example of radical submucosal dissection with extracellular matrix placement to prevent stricture formation. So what we did is just did overlapping EMR in this patient with high-grade dysplasia who was not a surgical candidate. There's multiple ways you can do this. Extracellular matrix is thought to create a systemic, non-inflammatory response that enables normal healing without stricture formation. And we simply just took a column of Surgicist, wrapped it around the stent, and then deployed the stent intraluminally, which you see here. And then 2 weeks later, you come back and retrieve the stent, which is perhaps the hairiest part of this procedure, because it's a permanent stent being used in a... Next slide, please. This is 1-year follow-up of this patient. There's a little repeat here of the first part. So this patient required one very gentle dilation, but had no dysphagia, no weight loss, and did very well. Next slide, please. So from this, we just said, is there a way we could peel out the inner layer of the esophagus and really deliver an entire sleeve to the pathologist that they could look up and just thus eliminate all of the confusion? And just say, here's the specimen, tell us what you find. And so we, Bart Whitman and Toshitaka Hoppo, who's here in the crowd, and I developed this procedure where we basically create a submucosal cuff, place a PEG tube, retrograde, bring the PEG tube up out the mouth, and then attach it to the cuff, and then draw out This is just copying what Akiyama had described for the stripping, and then basically deliver the entire specimen out of the mouth. And here's an example of that in a porcine model, and the porcine model always makes you feel good about yourself because you can just pretty much do anything to the esophagus and it works. But this is the stripping technique. So what you're seeing here is looking down the esophagus as it's being stripped from below. That trailing suture there enables you, in theory, to pull back and forth if you have to work in the groove in the mucosal-submucosal complex. So we did this in our first patient about a month ago. It was a 54-year-old male with a T1A, long segment multifocal high grade, who had an EMR of the T1A, and it had favorable biology. He was EUS PET CT negative, and we did a 14-centimeter circumferential resection. It took us a long time, and I think the part that I struggled with the most was creating that proximal sleeve circumferentially. There was no perforation, although he had a pretty striking pneumomediastinum, and he was discharged home in 3 days. He had one complication, which was he was positioned in the left lateral decubitus position and developed a myonecrosis of his left quad, and it was from a positioning issue. And this is him at post-op day 1. So we brought him back at day 9 to remove the stent. And what you see here is in retroflexion, you see the part of the matrix or the mesh which was not interfacing with the tissue, and it just sort of sloughs off. So this is looking back at the GE junction, and this is looking from the top part at about, I would say at about 20 centimeters or so, maybe a little deeper. And so we removed the stent, and what you see here is what looks like a skin graft. Is this sort of nodular sort of area. And this is him at post-op day 21. Doesn't look perfect, but he had no dysphagia. He was tolerating a textured soft diet, and he had pain at the G-tube site. We had him on 3-time-a-day PPIs, H2 blockers, and anything else we could think of in order to control acid. So I want to thank you for your attention. I had a lot of information I wanted to try and get to you, but I think those were the most important things. I want to thank several people that have helped support that work, particularly that you saw at the end. This is Dr. Yamamoto, who taught us how to do ESD. This is Toshi Hoppo, who's a good friend and colleague and my partner. This is Steve Badalak, who I was lucky enough to work with in Pittsburgh. He is the inventor of extracellular matrix. And it just so happened that we were in the same place and we started talking, and that's how this all came about. This is our weekly animal lab team with gastroenterologists, general surgeons, and a multitude of people. Jim Lukatich, who's really created the environment for me to, and for us to do this work. And then John Hunter, who really had the idea of the inversion one day when he was in the shower. He called me up after he got out of the shower and said, hey, I have an idea. Why don't we try this in the esophagus? And so we did, and that was the basis for the transhiatal inversion technique, which I'm basically just taking out the inner layer. So thank you very much, and I appreciate your attention.